Okay, so I am very happy to introduce Dr. Tom Saba, a pediatric pulmonologist from University of Michigan and Mott Children's Hospital. I wanted to say a couple things before Dr. Saba starts. So you have heard us talk about the consensus paper a few times over the last couple days. If you're not familiar with it, another plug to look at it. Really, this paper is a fantastic roadmap for families and physicians working with people with heterotaxy, but we wanted to make sure everybody knows that Dr. Saba was a main contributor to the consensus paper project. And it's continuing to do fantastic work with a group of investigators across the country, really committed to furthering our scientific understanding of heterotaxy and how we can improve treatment for our kids. So we are grateful.
All right, well, thank you very much for the introduction. So when I give talks at scientific meetings and to residents and fellows, I walk around a lot, and I just realized I'm not going to walk in front of the projector there. I walk around a lot, so I might not be oh, you are moving the camera. I just thought if you forgot what I look like, you look at my picture on Zoom. But anyway, I'm going to walk around. I like to engage the audience. You can ask questions in the middle. You can keep it to the end, whatever you like. We're here to share information and to learn something. I'm not here to give a lecture. I want to just make sure that we help each other out and teach each other a few things today. Okay, so we're going to be talking about the pulmonary issues among people with heterotaxy. And again, as Dr. Getty said, I'm not using the term heterotaxy syndrome. We might at one day agree that we all kind of use the same term, but I'm just going to be referring to the condition as heterotaxy today. So I do have some funding from the Genetic Disorders of Mucociliary Clearance Consortium looking at infections among children with primary ciliary dyskinesia, but that won't influence the content of what I'm talking about today. So here's what I'm going to try to address. We're going to talk about bronchial isomerism, so laterality defects inside the airways. We're going to be talking about lung disease among children with congenital heart disease. We're going to be talking about mucociliary clearance problems. We learned a little bit about cilia this morning. And then we're going to be talking about a condition called primary ciliary dyskinesia. Now, that is a rare disease, but it's very relevant to people living with heterotaxy because many people with heterotaxy also have that other rare disease. And then we'll talk a bit about how to assess and how to treat the lung diseases among children and adults living with heterotaxy. We'll start with bronchial isomerism. So these are the lungs. And so the lungs are asymmetric. You've got right lungs, which have a superior, let's see if the laser works. You've got a superior lobe, a middle lobe, and an inferior lobe, and they're separated by the horizontal and oblique fissures, respectively. And then you've got the left lung, which has a superior lobe and a left lower lobe. So these are not symmetric structures. They are asymmetric by nature. If you have heterotaxy, of course, this is using the nomenclature of isomerism, which doesn't necessarily apply to every heterotaxy patient. But if you have complete situs inversus, then the right-sided the left-sided morphology is on the right. That's bilobed lungs. And the right-sided morphology is on the left. That's trilobed lungs. If you have right isomerism, then the right morphology is duplicated. If you have left isomerism, then the left morphology is duplicated. It's hard to really know if the airways are kind of right morphology or left morphology, because on images and x-rays, the airways kind of look the same. So what morphologists and anatomists use is the specific anatomy and morphology of the airways relative to the pulmonary arteries to determine if there's right-sided or left-sided isomerism. And classically, the right main stem bronchus is short and eparterial, which means the right pulmonary artery is in front of it. The left main stem bronchus is long and hip arterial, which means the pulmonary artery is right on top of it. And so you can see that that is how the isomerism of the airways is determined, based on the shape and length of the bronchi and of the relationship with the pulmonary arteries. But the problem is, although one might be identified as right isomerism or left isomerism, Isomerism patterns are disharmonious. And I know that sounds like a little bit of a word that doesn't really apply to medical terminology, but that's the word that's used in medical literature. It's disharmonious, meaning you're not going to be completely right isomerism or complete left isomerism. You might very well have a combination of both. And sure enough, in this study, well, these are two studies actually that prove the same point. But the data here shows that among children who had right atrial appendage isomerism, that means like in terms of heart anatomy, it looked like the right side was duplicated. Only 91% had right-sided bronchial isomerism. 9% had left isomerism. Among kids with left atrial isomerism, meaning their heart looked like left-sided isomerism, only 45% have had left isomerism of the bronchi, and 55% had right-sided isomerism of the bronchi. In other words, the bronchial anatomy and probably the rest of the anatomy is not completely harmonious with either right or left-sided isomerism. So we had a meeting last night where we talked about whether some traditional definitions of heterotaxy are applicable. And well, adhering strictly to the term right-sided or left-sided isomerism might not really work for every patient because there's disharmony in that nomenclature. No. So now you might ask, well, who cares? I mean, what does it matter if there's right-sided isomerism or left-sided isomerism? Does it really make a difference for the patient other than just kind of seeing morphologically that there's this morphologic defect? And well, there's more than just isomerism. The airways themselves might be have an inappropriate shape to them in heterotaxy. So this was a study from China. They had 223 patients with heterotaxy. It's incredible. And they found that among those 223 patients, 27% of them had some type of narrowing or stenosis of the airways. So not only did those airways kind of shape morphologically on the wrong side of the body, they were narrowed or had stenosis. And this is a kind of reconstructed image of a distal trachea, and there's distal tracheal stenosis here. Here you can see the same thing on a CAT scan. This is a virtual bronchoscopy, and this is an actual bronchoscopy. And they also looked at those same patients and said, okay, fine. So there's bronchial isomerism. No problem. There's airway stenosis. No problem. Does that mean anything for this patient? That's really all that matters. We shouldn't rely on just kind of the way things look. We should ask questions. Does it matter for the patient? And so they looked at all the post-operative outcomes, okay? These children underwent like heart surgery, and they found that among those with lower airway anomalies, okay, that's the row that says yes here, the average day on a ventilator was 24 days. The average day on a ventilator for kids that did not have airway anomalies was about 10 days. There were no difference in the length of ICU stay or hospital stays, but they spent more time on a ventilator. That's a big deal. You're on a ventilator, you're going to get deconditioning and muscle weakness, and you might develop pneumonia. There's a lot of things that can happen if you keep a child on a ventilator for too long. Okay, so those are the kind of structural airway anomalies that me as a pulmonologist I consider in somebody with heterotaxy. Next, what are the pulmonary complications of heart disease? Well, this is not so much a lung disease per se, but having heart disease and undergoing heart surgery puts a lot of stress on the lungs. So let's say there's a vascular malformation. Your blood vessels didn't form properly. Well, in this case, this is something called a pulmonary artery sling, in which the left pulmonary artery comes off kind of the right pulmonary artery and goes behind the trachea. And there's also this little appendage from a normal structure in utero called the ductus arteriosum, and it kind of stays as like a ligament. And so you can see the distal part of the trachea is surrounded by blood vessels and this ligament, and that can actually compress the distal part of the trachea. And when you look at a bronchoscopy, it might cause tracheal narrowing. This is a normal shape of a distal trachea. This is narrowed trachea. That's called tracheomalacia. Another problem, well, a lot of times when there's a lot of pulmonary circulation, I'm sure many of you are familiar with this, those blood vessels can leak some fluid. It's called pulmonary edema, can cause a lot of problems for the lungs. This is an X-ray showing diffuse cardiogenic pulmonary edema. Pulmonary hypertension is when the blood pressure is very high inside the blood vessels in the lungs. That can be because of pulmonary veno-occlusive disease, meaning lots of kind of blood clots in the blood vessels. It could be because of narrowing of the pulmonary veins, which is what drains the lungs from blood. Or it could be any kind of left-sided obstructive lesion. If the left side of the heart is blocked, from an anatomical defect, that might build up pressure in the lungs, and it's called pulmonary hypertension. There could also be complications after certain types of surgeries. This Fontan surgery occurs in children born with, for example, hypoplastic left heart syndrome. And the complications of that surgery can be quite a few because of the fact the blood circulation is not pulsatile. It's more just kind of passive and slow flowing blood through the lungs. Most patients will have some degree of low exercise capacity, and we heard yesterday the importance of exercise programs in people with heart failure and Fontan surgeries. There could be development of arteriovenous malformations, meaning the blood vessels just build their own kind of connections inside the lungs. And there could also be this complication many years later called plastic bronchitis, in which the lymphatic system is so slow moving that it gets a little leaky, and some of that leakage develops into hardened kind of tissue inside the lungs. And that hardened tissue takes on the shape of the airways like this, and a patient can cough up something like that. It's called plastic bronchitis. That's kind of a rare but serious complication of a Fontan circulation. Now, of course, we also heard from Caitlin yesterday about the fact that lung infections are quite common, not only because of the fact that most patients have hyposplenic function, but it could also be because of simply the fact that you're living with a chronic disease, or that you have a little bit of malnutrition. Perhaps there's aspiration into the airways. Prolonged intubation, like prolonged mechanical ventilation, can lead to more infections. And of course, being in the hospital would increase your risk for having infections. And lastly, people who have heart disease are at risk for bleeding and blood clots inside the lungs. Now, let's talk a little bit about lung problems right after surgery. There could be some traumatic events during surgery. I mean, the cardiothoracic surgeons obviously do their best to avoid these things, but sometimes they might cause a little damage to what's called the thoracic duct and the chyle. That's like kind of the extra fatty fluid that's digested in the intestinal tract. That can leak outside the lungs into the pleural space called the chylothorax. Sometimes there could be damage to something called the recurrent laryngeal nerve, which innervates the vocal cords. And if the vocal cords get paralyzed, it could affect swallowing and voice. There could be injury to the diaphragm, which is like a dome-shaped muscle inside the chest that helps with breathing. There could be fibrosis or narrowing of the airway called the subglottic area from intubation. And of course, long-term, there could be some stiffness of the chest wall because of sternotomies. When you cut the chest open, it does lead to some scarring. That's a natural healing process, but it can lead to a little stiffness of the chest and lead to impaired breathing during exercise. And I do a clinic called a single ventricle clinic, where we see children many, many years after their Fontan surgery. And it's almost universal that there's some impairment in the lung function, oftentimes because of a stiff chest wall. So what about the postoperative complications, specifically looking at the heterotaxy population? Well, this was a study, I think this was from Pittsburgh. They looked at 87 patients with heterotaxy and 634 patients who did not have heterotaxy, and they looked at how they did after surgery. And so you can see that in looking at all of these outcomes, it seemed like there was a higher odds of these complications if you had heterotaxy. So there were a greater odds of post-surgical death, ECMO requirement, tracheostomy, and prolonged ventilator course. So this was one of the first studies over 10 years ago that showed that children with heterotaxy undergoing heart surgery, they have a rougher time than kids without heterotaxy undergoing the same surgery. Now, of course, they really didn't characterize these patients very well. We don't know if they had, spleens or gut malrotation. There probably was a lot kind of that was uniquely different among the heterotaxy patients, but nonetheless, having that diagnosis was associated with higher odds of complications. This was a study published last year. This was out of Stanford, and they looked at this database called the Pediatric Health Information Systems Database. They asked the same question: what are the post-operative complications in heterotaxy compared to children who don't have heterotaxy? And sure enough, the data looked quite similar. It appeared as though there was a higher odds of post-surgical complications among heterotaxy patients. And I specifically am highlighting here prolonged mechanical ventilation because well, that I think as a pulmonologist is something that I see as more of a long-term complication. It might not necessarily mean much like in the immediate postoperative phase, but years down the road, having been on a ventilator for a long time can actually lead to some complications in the respiratory system. They defined prolonged as greater than 4 days. This was the same group that published that paper in 2011, and they looked only at patients with heterotaxy. And they said, let me kind of stratify these patients with heterotaxy a little bit. Because I mentioned to you before, why did the heterotaxy patients have a rougher time? Was it their spleen? Was it their gut? Was it whatever? And so they looked specifically at one unique aspect of heterotaxy. They wanted to see whether their cilia were moving properly. I've got a lot more slides on cilia, but what they did was they looked at the cilia under a high-speed video microscope, and they quantified the pattern of the beating. So cilia have a very specific and stereotypical movement. And so they wanted to quantify, is the movement normal or is the movement not normal? So, you know, it wasn't a perfect study because there's way more careful definitions of ciliary movement than just normal or not normal, but nonetheless, they did that. And they looked at 13 heterotaxy patients with ciliary dysfunction and 14 without ciliary dysfunction. And they adjusted it for other risks and comorbidities. And they found, look, this is so interesting. Among those with ciliary dysfunction, there wasn't a whole lot different, except they had a greater risk for respiratory complications and had a greater rate of a need for beta agonists. This is like an inhaled medication for people that have like wheezing and chest tightness and stuff. There's no difference in the length of stay, days on the ventilator, or mortality. No patients actually had PCD. We'll talk more about that later. But nonetheless, these were early data from about 10 years ago. This is the first paper that really maybe showed that clinically having ciliary dysfunction in a patient with heterotaxy can be a problem. So we learned from these studies that there's a greater risk for pulmonary complications after heart surgery among patients with heterotaxy. Why is that? Could it be that they have some ciliary dysfunction? So here is a cilium. A cilium is an organelle. That means part of a normal cell, and it projects outside of the cell. It's a very complex structure. The basal body anchors it to the cell, and there's multiple microtubules that make up kind of the shaft of the cilium. And if you look at a cilium in cross-section, if you just kind of cut it right in half and then look down from above, you'll see that there's this really nice pattern of 9 doublets of microtubules on the outside and 1 doublet of microtubules on the inside. Now, this is a histological picture of a respiratory epithelium, like the cells inside the lumen of the airways. Down here is lots of collagen and connective tissue, but up here are these pseudostratified columnar epithelial cells. That's what they're called. These are the cells that are basically the protective barrier of the airways, okay? And on all of these pseudocolumnar epithelial cells, they all have a little nucleus in there. That's kind of the dark red dot. You can see that there's this kind of like, you know, crew cut on top, like this little hair, these little hairs, and they're all the same length, and they're nicely lined up one by one, and they beat back and forth all day long, 24 hours a day for your entire life. And the role there, well, until not your entire life, the life of the cell, which is probably just, you know, a few days. So for the entire life of the cell, it beats back and forth, and it clears mucus out of the airway. Now, again, this is a cross-section of a cilium. And the reason I'm putting this slide up is because, well, I'm not going to talk about each one of these genes. That would be the super boring. But what I will say is it's an incredibly complex structure. And there are hundreds of genes, and the genes encode proteins, and the proteins make up the entire structure we're seeing right here. And there could be defects, genetic defects in any one of these genes that would lead to abnormal function and structure of the cilium. So you can kind of get where I'm heading here, which is that ciliary dysfunction is an incredibly complex structure. Well, that seems to be the theme of this weekend, I think. There's nothing that simple in the life of a heterotaxy family. But And we're learning more and more. If I had put this slide up 5 years ago, it would have looked very, very different. But today, these are kind of the classifications of the categories of where the main defects will occur. Now, in mammals, there's 3 different types of cilia. And I'm trying to tell a little bit of a story here for how the cilia are involved in the pathogenesis of PCD and lung disease. Okay, there's 3 different types of cilia in mammals. There's primary cilia. Those are just, they don't move. They sense the outside environment. They're kind of like gatekeepers. They see what's going on around them. There's nodal cilia. Okay, these are in the embryo. They beat in a whorl-like pattern and create left-right asymmetry in the embryo. And they determine laterality. And there's motile cilia. These are those little crew-cut hair cells on the surface of the epithelial cells that beat back and forth all day and clear mucus. So 3 different types of cilia. So could it be that, here's the hypothesis, could it be that if somebody with heterotaxy has heterotaxy because of these nodal cilia aren't beating properly, well, maybe they have a genetic defect in those nodal cilia. And maybe that genetic defect also affects every other type of cilia in the body, including those cilia that clear mucus. That's kind of the hypothesis behind all this. So I know Dr. Geddes talked a little bit about this, but I took so much time doing this slide, I can't skip it. So here we have a mouse embryo, and in the mouse embryo is this little kind of teardrop structure called a left-right organizer. And inside the left-right organizer are cells on the inside called pit cells, and they have motile cilia. And on the outside are called crown cells. They have non-motile cilia. So the cilia on the inside create leftward flow. The cilia on the outside detect that leftward flow. And there's an asymmetry in calcium levels. And that calcium asymmetry then causes asymmetry in expression of nodal and expression of lefty 1 and multiple other genes. The point I'm trying to make is the establishment of left-right asymmetry is definitely involves cilia, but it also involves lots of other genes that have got nothing to do with cilia whatsoever. ZIC3 is the most common one. And I'm surprised Dr. Geddes didn't talk about it because she knows a lot about that gene. But anyhow, there's ciliary genes and non-ciliary genes. Okay, so this is like the movement of a cilium in the node, in the primitive embryo, okay? It moves like in this whorl-like pattern, and it's a unilateral leftward flow of fluid. Here's how the cilia move in the epithelial cells. It is a planar motion, back and forth, back and forth, back and forth, all day, every day, till the cell dies. And all it does is it does unidirectional movement of mucus out of the sinuses, out of the ears, out of the airways. And that's why you cough, because your cilia have been moving that mucus up your mucociliary ladder all day long. So if you look again at the epithelial cells of the lung, these are these pseudostratified columnar epithelial cells. There's a few extra ones in the middle that do other things. And your cilia are on top. And so the cilia live in this nice periciliary liquid. It's all water. And that water layer has to be the perfect thickness and the perfect hydration, the perfect amount of salt. And if there's not the perfect liquid and perfect amount of salt, the mucus will weigh down heavily on the cilia and they'll lose their mechanical advantage. So in other diseases like cystic fibrosis, for example, where there's dehydration of that water layer, the mucus weighs down on the cilia. There's not enough water. So the cilia don't move in that disease either. But the key for ciliary movement is not just the cilia structure and the cilia function and the cilia genetics, but also the environment around it. And I wasn't going to talk about this, but I think I will. So there is a new drug that's being tested for PCD, primary ciliary dyskinesia. And the whole purpose of that drug is to block a sodium channel on the surface of these epithelial cells. And by blocking sodium, they keep the sodium inside that water layer. And of course, we all remember from basic chemistry that if there's lots of sodium and salt, the water will come with it. So by blocking that sodium channel, it was proven that we improve the water layer here and the cilia work better. Could that be a solution maybe for anybody with some type of ciliary disease, including patients with heterotaxy? It could be one day. So I think I kind of already asked these questions. So the question is, if cilia are so involved in organ laterality, And cilia are so involved in mucus clearance. Well, then doesn't it make sense that people with organ laterality problems would have mucus clearance problems? So let's see if that's true. So Adam Shapiro and the gang from a few years back looked at this very question, and they looked at people who had heterotaxy. This was a web-based survey, and I wouldn't be surprised if some of you in this room actually participated in this survey. And they stratified patients into those who have had surgery and those that hadn't had surgery before. Because theoretically, I mean, maybe if you've had heart surgery, you might have different pulmonary symptoms based on the surgery itself. And in any case, they asked if, does your child have any symptoms of PCD, like chronic coughing, recurrent pneumonia, lots of ear infections, those types of things? And sure enough, even those who had no prior cardiac surgery, nearly half of them had symptoms of PCD, chronic coughing, wheezing, nasal congestion, etc. It was the numbers of symptoms were actually kind of similar, whether you had surgery or didn't have surgery, but nonetheless, a lot of those, many people who never had heart surgery still had a history of recurrent ear infections, year-round daily nasal congestion, recurrent sinus infections. And so you might ask yourself, well, why on earth would somebody with an organ laterality defect, heart disease, asplenia, all the things that go along with it, why are they getting recurrent ear infections? What do the ears have to do with it? Why are they getting sinus infections? So then we started asking more questions. Well, maybe it's the cilia problem. And so I did this study that we published a few years back, and I took a bunch of patients with heart disease and stratified them into 4 groups. Situs ambiguous, which is kind of another name for heterotaxy. We can get semantic here, but let's just say it's heterotaxy. Heterotaxy with complex heart disease. Heterotaxy with simple heart disease. It's like you had a VSD. Situs solitus, which means no heterotaxy and complex heart disease. No heterotaxy and simple heart disease. And so what I did was I tested nitric oxide levels. And I'm going to talk more about this, but nitric oxide levels in the nose, it's a natural gas. We all produce it, nitric oxide. And for reasons we don't totally understand, people with primary ciliary dyskinesia have really low levels of that gas in their nose and sinuses, like really low levels. And so that's one of the diagnostic tests for PCD. And so I looked at nitric oxide levels among people with all these different heart defects. And it turns out that I picked up low nitric oxide levels in everybody on average in those with complex congenital heart diseases. Didn't really have much to do with the fact that they had heterotaxy or no heterotaxy, but if you had a complex heart disease, you had a generally lower level of nitric oxide. Now, this nitric oxide level wasn't low enough for me to call these patients PCD. You got to have a really low level. This is still within normal range, but it was way lower than those who had simple heart diseases. And as we know, cilia are very much involved in the development of the heart. So we got a few signals here. Heart disease, lower nitric oxide levels. We also did genetic testing on these patients, and among those who consented to it, we found a bunch of genetic abnormalities, but none that really confirmed a diagnosis of PCD. Because many of these were just kind of like heterozygous, in other words, just one mutation. But again, you need 2 to have a disease. So the genetics didn't really hold up. We found a bunch of mutations, but none for me to really say that these children had PCD. So this was a study that looked at something quite similar. They had 43 patients with heterotaxy and congenital heart disease, and they did ciliary motion on all of them, looked under the microscope to see how those cilia were moving. And they found 18 patients had ciliary motion disorders. And again, this was not the frequency. This is just looking, and somebody said, it looks abnormal. So not a perfect study, but nonetheless, I think this is important to know. So among those that had ciliary dysfunction, they also had relatively low levels of nitric oxide compared to those that didn't have any ciliary dysfunction. So far we're learning here that in a good group, 18 patients out of 43, they have ciliary dysfunction and low nitric oxide levels. The important thing to note here is none of these patients satisfied the strict diagnostic criteria for PCD, okay? But it wasn't normal either. What does this mean? This is also a little bit of a summary. So they looked also at the respiratory symptoms of these children, and they found 5 out of 8 subjects with ciliary dysfunction had respiratory symptoms, but none of the normal ciliary function patients really had any significant respiratory symptoms. They did some genetic sequencing. They only looked at 14 genes, and now the commercial panels are up to like 50 genes. And they found a few heterozygous mutations, but again, nothing that really confirmed PCD. So this was another really great study that was also out of Pittsburgh. So Pittsburgh did some amazing work back in the day on ciliary dysfunction on people with heterotaxy. Many of you might be familiar with some of those papers. Here's some of them. So they had 218 patients with congenital heart disease, including 39 that had heterotaxy. And Ali, I think I'm going to stay put because I think are you following me with the camera, or is it doing it on its own? Okay, I don't want to make you do more work, but anyhow. All right, so here we go. So 39 patients with heterotaxy. And so they only really did testing on 30 patients with heterotaxy, 128 without heterotaxy. And they looked at nitric oxide levels. They looked at abnormal ciliary motion. And only 6 out of the 30 had normal nitric oxide, normal ciliary motion. Everybody else had some problems with nitric oxide or abnormal motion. When they looked at the non-heterotaxy patients, 49 of them had no problems at all. So in other words, way more patients with heterotaxy had some features of ciliary dysfunction compared to those that didn't have heterotaxy. Then you might be asking, hang on a second, 33% had abnormal motion and 11% had abnormal nitric oxides among the non-heterotaxy group. Well, what do you make of all these abnormal tests in the non-heterotaxy group? I totally understand. These tests are not perfect, and they're not diagnostic tests. They're simply descriptive tests. And the description here is that there was a greater degree of ciliary dysfunction among those with heterotaxy. In this same study, they looked at symptoms. And so they compared those with abnormal ciliary motion and low nitric oxide. Let's just kind of cancel the third column. This is the most interesting one. So abnormal ciliary motion and low nitric oxide, again, these are kind of indirect signs and features of ciliary dysfunction. And they compared it to those that had normal ciliary motion and normal nitric oxide. Well, there was way more symptoms among those with abnormal ciliary motion and low nitric oxide. In particular, more PCD-specific symptoms and more lower respiratory symptoms. So not only did they find that there was some indirect biometrics of ciliary dysfunction, low nitric oxide levels, the cilia didn't beat well on microscope, they also had more symptoms. So now, one kind of last piece of data I need to share with you to prove my point is that this study looked at they just kind of listed off all the genes we know about today that are probably related in the path to the pathogenesis of heterotaxy. And if you look at this list, you'll notice that many of these genes are very closely involved in the structure and function of cilia. Not all of them, but many of these genes are also, when mutated, can give you a diagnosis of PCD. So we have, in patients with heterotaxy, generally low nitric oxide levels, generally a higher rate of ciliary dysfunction under the microscope, and a lot of genetic defects that are directly related to ciliary structure and function. This was I think this was a Chinese study from last year. Yes, they did genotype analysis, whole exome sequencing or CNV sequencing on 72 fetuses with heterotaxy. This was before they even were old enough to have symptoms or do nitric oxide testing or any other test. They came out, they did genetics right away. And they found that 5 of these 72 patients right away had genetic problems that they would label as primary ciliary dyskinesia. Okay, like for example, CCDC114, DNA H11, these were compound heterozygotes, meaning they had 2 mutations, okay, and they were both pathogenic mutations. And so 5 out of those kids right away, they were able to find genetic abnormalities and call it PCD. What was interesting about this study is that they really did not pick up a lot of the genetic defects we would have expected them to, like ZIC3 and, other things, but it was really interesting that there's a lot of very specific PCD related genes found in this review. So now let's talk about primary ciliary dyskinesia. I tried to give you some data to support the hypothesis that children with heterotaxy probably have impaired ciliary motion, which leads to symptoms, particularly maybe like post-operative symptoms. But it's not bad enough for them to immediately come to medical attention and for somebody to say, this child definitely has PCD. But nonetheless, it's not mild enough for us to ignore it either. Let's talk about PCD so we have an understanding for what one end of the spectrum actually looks like. The incidence is expected to be 1 in 11,000 to 1 in 16,000. But of course, there was a study that came out last year that said that when you do some population genetics, the prevalence of PCD is probably closer to 1 in 7,500 people. It's mostly an autosomal recessive disease, but there could be X-linked forms and autosomal dominant forms. The traditional teaching is that organ laterality defects occur in about 50% of cases. Among those, 6 to 12% have heterotaxy. The diagnosis is not easy to make. It requires specialized equipment, and you kind of need to know what you're doing with it and how to interpret it. And the management is not standardized either. So children and adults who have PCD almost universally have a chronic daily wet cough. They almost universally have chronic daily nasal congestion. 75 to 80% were born with some form of respiratory distress, like they needed oxygen or CPAP. That's really tough to figure out if that's the case among somebody also born with a heart disease, because they could have the respiratory distress because of the heart disease. 60% of children and 98% have bronchiectasis. And that's what I'm trying to illustrate in these images here. Bronchiectasis is when the airways are really dilated and thick. And that is kind of a sign that the lung damage is I don't want to use the word extensive, but it's pretty severe once you've developed bronchiectasis. Most people will have infertility, both men and women. Or subfertility. I don't want to say infertility, but bearing children naturally is challenging. Almost all of them have frequent ear infections, and up to 20% of patients with PCD will have this airway infection from a bacteria called Pseudomonas aeruginosa. Now, most people in our society will never have that infection, even though Pseudomonas lives everywhere. In fact, it's probably somewhere in the ducts in this room. But we have immune systems in which we're able to clear it and cough it out, and it doesn't cause any problems. But if you have lung disease, the Pseudomonas can stay in your lungs, and it can actually cause worsening lung disease. So it's pretty serious infection if you have it. Of course, there are ways to eradicate it and treat it without really a whole lot of problems. But in somebody with lung disease, we do regular surveillance to see if they've developed this infection. Here are some of the diagnostic tests that the PCD Foundation has established to diagnose PCD. On the left here is transmission electron microscopy, and Caitlin described it to us yesterday, in which you take a biopsy from inside the nose or the trachea, and you have to do some really specialized kind of pathology-related things, and I'm not exactly sure what they do or how they do it, but they cut the cilia right across, and then they look under this electron microscope, which is a super high powerful microscope, to look at the structure of the cilia. And so they can identify if there's a problem based on the way it looks. Here's a young lady doing nasal nitric oxide. Transmission electron microscopy is a really nice test to do, but it only picks up 70% of cases. 30% of people with PCD will have totally normal appearing cilia. And that's kind of understandable, because remember when I showed you that slide about how complex the ciliary structure is? You're not going to see every little detail on electron microscopy. So you missed a lot of cases on electron microscopy. This young lady here is performing nasal nitric oxide testing. So you collect the amount of nitric oxide in the nose. It's very easy. It doesn't hurt. It takes about 5 minutes. It's really sensitive and specific, but it's only validated in children older than 6. So if any of your children have had nitric oxide testing done and they're not 6, I wouldn't trust the results, because low nitric oxide levels might be totally normal in a child, in a preschool age child. The other test, of course, is genetic testing here. And of course, with the commercial panels we have on the market today, and many of the panels that your local hospitals have, it probably only detects about 70% of genetic abnormalities that truly are known to cause PCD, because it's hard to keep up. And these panels have to get, new development and new genes added every couple of years or so. So you can see that none of these tests are perfect. And that's why you need to do at least 2 of them and have them interpreted by somebody who's specialized in PCD clinical care before you can actually firmly make a diagnosis of PCD. Of course, can you do all of these tests on somebody in whom you suspect any type of ciliary impairment? Of course you can, although I just don't know what's normal and what's not normal and how you might interpret them in a child with heterotaxy, and when I might say this is mild ciliary impairment and this is severe ciliary impairment. All we can really say now is, well, it's PCD or not PCD. My gut feeling is we should be able to quantify ciliary dysfunction better than this, but we're not quite there yet. There might come a day at which we could do such a thing. So how do we treat PCD? Well, the children with PCD and adults should be seen in specialized centers, and there's a network of about 25 centers around the country that are considered these centers of excellence. They need to see ear, nose, and throat docs because it really affects their ears and hearing. And if you have hearing problems, you might have a learning disability, and so we take that very seriously. Psychosocial assessment is a major part of our care because the quality of life among children living with heterotaxy is not as good as it should be, and we have data to prove that. Lastly, preventing and controlling the spread of infections is a huge part of our work. We get regular respiratory cultures every time we see our patients with PCD because we're trying to make sure that they don't develop these serious infections called Pseudomonas. We use antibiotics a lot. We use airway clearance, which means breathing treatments and percussing the chest to help the children cough up that mucus that their cilia can't get rid of. The one kind of therapy that has been proven to be effective is azithromycin. This is an antibiotic. Many of us use it for, sinus infections or whatever, but it turns out that if you take azithromycin 3 times a week as a chronic therapy, it doesn't really work as an antibiotic. It works like as an anti-inflammatory medicine. And you can see here from the data in the top right, this came out of Denmark a few years ago. It showed that among people living with PCD, if they're on chronic azithromycin therapy, that's the red line, they have a much, this is going to be complicated, a much greater rate of no exacerbations. So in other words, they had fewer exacerbations, but when you do kind of these like Kaplan-Meier curves, you have to phrase it a certain way. So they had fewer exacerbations. Let's just put it that way. It works. Many children with PCD need inhaled antibiotics to suppress chronic infections. Okay, so here, let me help you. Let me tell you a little bit about our experience with PCD. 8 years ago, I went to one of the first PCD conferences in San Francisco in a room much like this one with a number of people and participants almost exactly like this. And we all sat down and we said, we need to build clinical and research centers for PCD. And there was about 2 or 3 at the time. And now the PCD Foundation has launched this wide network of PCD centers around the country in which we have guidelines and accreditation visits. And it's really been quite remarkable in how much we were able to help children living with PCD because of these clinical centers around the country. We also have published guidelines for PCD diagnosis and care, and we are now working on a national registry, which is a way to look at everybody with PCD and their clinical phenotype and their genotype and all of the things we need to look at to make sure that they live great lives. And that's a huge undertaking, and it's going to turn around, I think, big time the way we help our patients with PCD. So here's kind of how I look at the relationship of PCD and heterotaxy. And I might be way off on this, but this is my understanding. So bottom right corner here is everybody with PCD. Let's just call this North America because the numbers might be a little bit different across the world. We don't know. Anyway, so PCD, 1 in maybe 15,000 people. We know that about half will have laterality defects. And so that's why there's the big circle, laterality defects. Half of PCD have that. And about 6 to 12% of PCD patients have heterotaxy. And of course, from previous studies, we know that among anybody with laterality defects in this country, most of them are going to be heterotaxy and not situs inversus totalis. So that's why I drew it the way it is here. So, right. So that's kind of how I think things look. What we don't know is, okay, so I know if I have 1,000 people with PCD, I can predict how many of them are going to have laterality defects and heterotaxy. If I have 1,000 patients with heterotaxy, how many of them are going to have PCD? Well, it looks from my circles here that a small proportion will, but it's not negligible. I mean, it might very well be 10%. I have no idea, but that's my projection of what the numbers look like. Or maybe there's something like this. Maybe there's a totally different population of people who don't have PCD, but they've got mild ciliary disease and they have heterotaxy or a laterality defect. They don't satisfy the criteria for PCD, but they do have problems that need to be taken care of. So I think this is what it looks like. And how do we find these patients? Well, we start with the heterotaxy group. And among those with heterotaxy, we should be asking these questions. Do you have unexplained neonatal respiratory distress in the term infant? Again, that's tricky because over 80% of children with heterotaxy will have cyanotic congenital heart disease, and maybe that's why they had neonatal respiratory distress. Okay, so that's not going to be an easy one to look for. Do you have year-round daily coughing? That's an easy question to ask and an easy question to know the answer to. Do you have year-round daily nasal congestion, which began before 6 months? Also a very easy question. This screening is very easy to do. And do you have an organ laterality defect? Well, of course they do. So if you have 2 out of these, then you should get further testing done. And that testing includes some of those diagnostic tests I mentioned before, the ciliary biopsy or the nasal nitric oxide testing or genetics. Now, in our guideline, we said patients, so among everybody with heterotaxy, patients should be screened for clinical signs and symptoms suggestive of PCD. So docs should be asking, well, and parents, of course, and you bring it to your docs because docs might not even know to ask these questions, but you should raise these issues. If children have 2 out of these 4 criteria, this should be a sign that you should look into it. Now, patients with chronic wet cough, chronic nasal congestion, recurrent pulmonary infections, or unexplained post-operative complications, like, for example, if the child was on a ventilator for longer than expected after the heart surgery, they should be referred to a pediatric pulmonologist to evaluate for PCD and other lung diseases, because don't forget, there's lots of lung diseases that you can have with heterotaxy. Evaluation for PCD should include these tests we talked about before. And here's an important one. Perioperative optimization for lung function with antibiotics and increased breathing treatments should be considered among patients with PCD or other forms of chronic lung disease or a history of postoperative pulmonary complications. So you don't only have to determine, is this PCD or not PCD? You should make sure that, or we should make sure that children with heterotaxy are in tip-top shape prior to surgery. So if you need to see a pulmonologist to investigate and get an x-ray and maybe, you know, start some breathing treatments to make sure things look really good before surgery, we should be doing that. I know the group of Boston does that. So now where are we with research and clinical care? So this kind of, I jotted a few notes from our meeting last night. We've got a bunch of docs from across the country looking into this. We're having meetings quarterly, and we're working on agreeing on a clinical and research definition of heterotaxy. For example, does everyone with heterotaxy have to have heart disease? Probably not. Do we use the word syndrome? I mean, these are kind of, you know, syntax issues, but it's important. We're trying to build local registries. So everyone with a big heterotaxy population is trying to dive really deeply into everyone who's got heterotaxy and really learning a lot about them. And maybe one day we'll have a national registry, who knows, but that would be really, really cool. We're trying to also look at outcomes. For example, we've looked at some immediate postoperative outcomes, and I asked yesterday, what are the 20-year outcomes after heart surgery in somebody with heterotaxy? We don't really know a whole lot yet. We'd like to standardize our care a little bit, and that's what that guideline was written for last year. And this is not something we talked about, but what should we do about infections? I mean, should we be wearing gloves and gowns every time we see a patient with heterotaxy? Because they might have infections that we don't want to spread, and other patients might have infections we don't want to give to them. So I don't know. These are the things we've got in mind. I also asked some of the leadership of the HC, which is what I call you guys now, the HC. I asked the leadership yesterday, what are your questions, parents? What do you need to know? Because I don't know what it's like having a child with heterotaxy. I mean, I know my research questions because of what other people have published, but I don't know what it's like raising a child with heterotaxy. So we would love to learn a little bit about what your, as parents and heterotaxy advocates are looking for. I learned a little bit about that yesterday. That was very helpful, but the HC and the docs around the country need to continue this partnership. Right. Thank you so much. As you walk, Nick, I'm going to answer the chat question. If we answer yes to all of those questions, but genetics didn't show anything and the child is younger than 6, should we still get a referral to a pulmonologist just to be proactive? I think so, Rachel Mattingly. I think you should, because there are lots of additional ways a pulmonologist can help. I don't think the question should be, is it PCD or is it not PCD? You can answer yes to all those questions because your child has asthma, or because your child has a small eustachian tube, or because your child had an infection that they never really got over. So you should seek consultation with a pulmonologist if you have questions about your child's pulmonary health. You shouldn't only be worried about the PCD question. So to answer your question, Rachel, yes, I do think you should get a referral to a pulmonologist.
I am going to ask 2 out of my 30 questions. First one being going back to those criteria of who should be assessed. And we're kind of in that camp where we had a child with, when she was very young, issues with respiratory distress. We know that she's complex heart. She had laryngomalacia and all that fun stuff, but did not have extensive evaluation for PCD. She does not have any chronic symptoms since, but we can say yes to the top one and the bottom one. So it's kind of like this gray area. Nobody wants to assess for it because, well, she seems fine, but she has heterotaxy. She's had respiratory distress in the past. She's been intubated for longer than expected before. So what do you do with that?
Okay, well, again, I guess I'm just going to go back to the point that there's more to lung disease and heterotaxy than just PCD. And I would say that somebody who's had heart surgery and been intubated and had laryngomalacia might very well have some chronic lung disease. And sometimes it's an unsatisfying term to say chronic lung disease, but it's just kind of a term we use for somebody with chronic, maybe inflammation or a history of infections that led to some chronic respiratory issues, but probably needs treatment. Maybe for a lot of people with chronic lung disease, they need a lower threshold to treat with antibiotics and steroids during acute viral illnesses. It doesn't necessarily mean that we're going to put a label on a lung disease per se, but that we could perhaps have a partnership in treating infections and maybe talking about exercise capacity and participating in sports when they're a little bit older, or at a bare minimum, getting yearly pulmonary function tests to just kind of see where we're at. Because yes, people with heterotaxy are at risk for airway malacia and chronic aspiration and postoperative complications and so many other lung problems, and not just PCD. I might have put too many PCD related slides just because I think it's a fun, interesting concept that we're trying to dig deeper into, but I don't want to trivialize or minimize the fact that there are other things that might affect lungs and breathing besides PCD and ciliary impairment.
Okay, that's very helpful. Thank you. My other one could open a huge, giant can of worms, but I just want to throw it out there because heterotaxy, period. We are always talking about these correlations between pulmonary function and cardiac function. and how it relates to cilia and the development, but I don't hear a lot of talk of how that trickles down to gastrointestinal and those lower organs where, you know, there's issues with flow and function. And you know, with my extremely limited knowledge, my question keeps coming up year after year. That whole cilia function thing, is there any talk between the guys that talk about the upper half of the chest and the guys that talk about the lower half of the chest, if there's a relation there?
Yeah, you mean the guys that live in the basement? We don't talk to them very much. But so here's the thing, boy, you have a great question. First of all, we should probably invite a gastroenterologist one year to this conference. Okay. Secondly, the cilia in the gut don't necessarily have the same function of kind of clearing things that they do in the lungs. The cilia in the gut do something a little bit different, and they're much kind of bigger and longer. And so I am not aware of ciliary problems causing gastrointestinal disease, other than if there is like malrotation of the gut. Because certainly cilia are involved in rotating your gut properly. And so if you have malrotation, you can get volvulus, and even an unrepaired malrotation you can still have intermittent gastrointestinal issues. But I would say that is just simply not quite like kind of a chronic active cilia problem, I think, but I don't know. I don't think anyone really knows. What I will tell you though, is that among children with PCD, okay, that's kind of like the classic cilia disease. In PCD, there are some gastrointestinal issues, mostly related to the fact that their organs and their gut had malrotation. But among PCD patients without any gut malrotation issues, generally speaking, GI symptoms are rather minimal. So I don't think it's an active cilia thing. I think it's more of a gut malrotation thing. But I don't know. We should ask a gastroenterologist, because I don't have a great answer to that question.
Motility affected by blood flow. Isn't motility affected by blood flow and circulation? So if you have heart defects or you're chronically sick, you're going to have your motility affected because the blood flow isn't going to the rest and digest.
Fair enough. Look, I mean, perhaps I should have answered your question by acknowledging that heterotaxy is a multi-organ systemic disease that affects every organ, and they all interact. Yes, that is entirely true. Okay, it could be an interaction of the cardiac output and the blood flow and things like that. But is it specifically a cilia-related problem? I don't believe so. Okay, let's go to the chat here. Okay, what is a good term to call someone that has heterotaxy with complex congenital heart disease, tracheobronchomalacia, and other respiratory symptoms, however, who is not diagnosed with PCD, right? Gene testing previously done only showed mutations from parents in different PCD chromosomes, not the same, and the nitric oxide was really low, but within threshold range. The child is currently treated similar to those PCD. Okay, so here's what I call, oh wait, there's more. After surgeries, and takes a little longer to get out the ventilator. Okay, so here's what I call them. I call them probable PCD. Okay. And that is a thing. Okay. I have a whole registry, and you're either PCD or probable PCD. In my probable PCD patients, I say probably there is a ciliary impairment contributing to their lung disease, but I haven't proven it according to the PCD diagnostic criteria. In those probable PCD patients, I treat them like they have PCD until things get clarified. I don't know, maybe they will, maybe they won't, but we repeat genetics, we repeat biopsies, we repeat nitric oxide testing until we really nail it down. And in the meantime, we call it PCD, probable PCD. The problem is that it's tough to get expensive equipment approved if you don't have a firm diagnosis. But I don't withhold. It's better to kind of treat for a diagnosis rather than withhold treatment because you're not sure about the diagnosis. So that's what I call them, probable PCD. Let's see here. Next. Our geneticist said that my daughter is unlikely to have PCD, but she has been diagnosed with mild asthma. Should we explore PCD further? She has never had any biopsies or specific testing done. Her symptoms are throughout the day, raspy breathing, barking, coughing with any cold that lasts 3+ weeks. She has 2 left lungs and her bronchial trunk is reversed. Okay. So firstly, I also want to acknowledge the fact that asthma is a common disease. PCD is a rare disease. Heterotaxy is a rare disease. So let's not kind of, forget about the fact that people with heterotaxy can also have other things that are common, like asthma. So if a child does have chronic symptoms, yes, this child, Jessica, should be seen by a pulmonologist. Do you need to dive deeply into PCD? Well, I don't know if your child's had any other testing like nitric oxide, but a nitric oxide is very easy to do so long as she's older than the age of 6. And if your nitric oxide level is normal, you probably don't have to worry too much about the PCD question anymore. But it seems like there are things that one might be able to do to help your daughter with the barking cough and prolonged colds. I have diagnosed many patients with heterotaxy and many people with PCD with asthma because it's a common condition. And we don't want to forget about that just because they have another condition.
Dr. Saba, thanks. That was such a fantastic talk. And I love learning more about the pulmonary aspects of heterotaxy. So thank you. Kind of a theme that's been touched on a little bit or quite a bit is when you don't quite have the diagnosis of PCD, but there are clearly signs and symptoms along that line. And I'm thinking a lot about our patients who are undergoing cardiac surgery, perhaps at 4 months of age or 6 months or even a year, who haven't necessarily had the system stressed, as it were. And one of the things that we're very interested in is an airway clearance regimen leading into surgery and after surgery. And so my specific question for you as a pulmonologist is, do you think it's a reasonable approach to assume that there is some degree of ciliary dysfunction in a child with heterotaxy and treat them as such going into and following their surgery?
So yes, thank you. So well, let's kind of answer that question by painting 2 scenarios. So scenario number 1 might be a little bit easier for me to answer. Let's say it's a child who has some type of a chronic respiratory issue and has heterotaxy going into heart surgery. Yes, for sure, that child ought to have optimization of health with airway clearance and breathing treatments going into the cath or going into the surgery, because that might minimize the post-operative complications that we've seen over the last few years. The more difficult question to answer is, what about a child, maybe a baby, who really doesn't have a whole lot of pulmonary symptoms? Is it worth assuming that there could be some post-operative complications and treating them anyway? Well, I guess I don't know. Probably the answer is yes. If I had to justify that with data and with anecdotal experience, I don't know if I can do that. But based on what we know about the rate and the risk for ciliary impairment and the postoperative outcomes among children with heterotaxy, it makes a lot of sense to do that. I have definitely done that in all my heterotaxy patients who have lung disease, but among those that have never seen a pulmonologist, well, I guess I could say that we don't implement that practice simply because probably those children have never really been seen by a pulmonologist before, and many of the cardiologists might not even consider this to be a real, necessity. I think the answer, Dr. Shidlow, is we should be doing that. So this might actually be the role of the parents to advocate on behalf of the children, to say, we know about this risk. Do you think maybe we should talk to a pulmonologist or stay for a day in the hospital, a day before surgery, to kind of get things cleared out as best we can? Of course, it's probably patient specific. Maybe in a child who's really doing exceptionally well, that additional therapy day or 2 might not be worth it. But perhaps we should agree that a consideration for pre-op optimization of respiratory health ought to be considered for everybody with PCD. With heterotaxy.
That's right. Wonderful talk, Dr. Saba. I think Heterotaxy Connection has really opened my eyes to see that it's not just the heart. There's really multi-organ system involvement for people with heterotaxy laterality defects. And I think that's also probably shows us how even more important it is that we collaborate together. We form these registries. We look at patients, because I wonder if there could be a portion of patients who have their laterality defect, their heterotaxy, and sort of the damage is done during embryogenesis. And perhaps there are other patients who have ongoing multi-system organ dysfunction after birth, and identifying those patients will help us understand who's might have a higher risk during surgery, or even like longer term follow-up, teenage life, adult life, and what sort of things we should be doing for them and how we should be following them. And I was just wondering sort of what do you think is sort of the best way to go about that?
You're talking about like like diagnosis and phenotyping early.
Exactly.
Yeah, you're probably right. Tough to do, but like, so the whole idea of, well, I don't know if we'll go as far as to say newborn screening, because there might not be any type of screening test, but who knows, maybe there is. But the whole idea of newborn screening is that you identify a condition really, really early, and you institute treatment really, really early. Like, well, cystic fibrosis, because I deal with that. You diagnose it at birth, and then you immediately start the children on aggressive nutritional interventions and pancreatic enzymes, and the outcomes have been tremendously better as a result of that. Could it be that newborn screening of heterotaxy might also improve outcomes? I love that idea, and it's the right idea. How do you do that? I mean, I don't know. But early diagnosis is probably the right way to go about it. There's not going to be like, a heel stick, but it could be that maybe if we recruit the neonatologists to say, if you pick up a congenital heart disease and one or two whatever other features, I don't know how we're going to say it, let's make sure that the diagnosis of heterotaxy gets put into this child's chart really, really early. Because here's another thing. I see a lot of children who I think to myself, well, this child's definitely got heterotaxy, but nobody ever said that before. So we get it in the chart. That might be the most important intervention in early diagnosis, is not really intervening with different interventions, although maybe we'd start them on prophylactic antibiotics a little bit earlier. I think there might be a few things we could do early. I love the idea. Let's work on it. I don't know how to implement it, but yeah, for sure.
So you mentioned a bit, and I guess piggybacking on a previous question, when she was asking about GI, you mentioned infertility being an issue. So I guess the open-ended question would be, in your patient cohort that have some version or spectrum of ciliary dysfunction up to PCD, what are other systemic issues you've seen in those patients that are likely cilia?
I'll tell you what, Renee, the problem is we don't know. And that's exactly what we need to look for, adult outcomes, okay? Like, I know in people with PCD, simply based on the biology of cilia, they're going to have subfertility. But do people with heterotaxy have infertility or subfertility? Well, I mean, we heard yesterday there's a few patients that have, had children, I guess. But I think there is, if we looked at it, we would find that is a big issue. And that's going to be one of the things we look at, like kind of in this longitudinal registry, where we do a cross section of everybody with heterotaxy in the country, and we follow them over 15, 20 years, and we kind of see what happens. That's what we need to do. So what are the kind of adult complications and outcomes, including infertility? I don't think anybody knows that. Okay. We just have one more question. Okay, Dr. Getty's here. Something I currently have no evidence to support, but have often thought, is that we have some indirect evidence from congenital heart disease patients, there's something about regarding fertility that is suggestive of ciliary dysfunction. The recurrence risk for men is half that of women, and I think the sperm works less. Okay. There you have it.